DKFZ. It's an important session of Nicholas Val as a preparation for the hands-on session on treatment planning tomorrow. So Nicholas Val, after Professor Galalae, will give us a demonstration of the installation of MATRAD. So I recommend that all users who would like to benefit mostly from the hands-on session that we're going to have tomorrow on treatment planning, a very interesting session, I would recommend that you stay also for the session by Nicholas Val at 5:30. We now proceed to our next case study on prostate. Professor Galalae, thank you again for being with us for the second time this afternoon. I give you the floor.
Thank you very much again. So I have the luxury to first to speak twice. So it's a luxury, really. Many thanks for that. So I have time to explain the midostaurin approach in carbon-9 radiotherapy for prostate cancer, and also to speak in the same session with Roberto. That's fantastic. Thank you very much. Well, so based on the first lecture, I would actually continue in order to catch up and also to explain you our approach at midostaurin. So, on contrary, as we heard from Roberto, on contrary to the colleagues in Heidelberg, we actually very much appreciate the long-term results of the Japanese J-Cross group. And of course, this is the very base of everything which should be done in carbon-9 radiotherapy. I think the Japanese colleagues, they have 1 or 2 decades more experience than all other centers in the world. So especially in prostate cancer. So I just remind you of this slide. So 20 years results in a high number of patients. You can see here from 6 institutes, prospective designed trials. That's very close actually to level 1 evidence. And I really agree with the thoughts Roberto shared with us. It's to do a randomized trial is also difficult in prostate cancer from the other perspective, because imagine we treat in such a center many other rare disease children, difficult to treat disease with no other option. And when we come up with a randomized trial for prostate cancer to demonstrate a survival benefit of, let's say, 5% or so, then we need maybe 2,000 patients or more. So that will be difficult, to trade off with our colleagues from other specialties to treat these patients physically. I mean, that's a challenge too. I mean, for those of you who have experience with particle therapy, that's not so easy to treat 100 prostate cancer patients per year in a center. So I think that's quite a challenge. So the 4 pillars of treating SIRT or using SIRT for high-risk prostate cancer at midostaurin are first the ascended trial, the level 1 evidence in the combo arm, the J-Cross hypofractionation, ultra-hypofractionation 10 and 20 years results, then the KILL experience from brachytherapy, and of course the level 1 evidence in hydrogel spacers. So here are actually the elements we actually used. You see here from ascended trial, because we think this is the reference for everything. It's a level 1 evidence. We use elective node irradiation and for high risk prostate cancer, and of course try to lower the toxicity, which was relatively high in the ascended trial in this arm. Then from the J-Cross, we use ultra hypofractionation, 12 fractions, 4 fraction as used in Japan. And of course, as Piero has nicely explained today, but also yesterday. So the dose was actually translated from the MKM to LEM model 1. So we came up with this 4.8 gray RBE per fraction. From the Kiel brachytherapy group, actually, we learned the dose intensification of equivalent dose to gray per over 5 grays. This was actually what we aimed for the tumor regions of the prostate, so the peripheral zone, the tumor itself. Then the relative urethra sparing, I will show you in detail, and the more peripheral distribution of those. Yeah. Then the rectal spacer study, the phase 1 study, showed us actually that we cannot only use, or we can use the spacer not only to reduce the rectal dose significantly, but actually also to distribute differently the intraprostatic high dose to lower prostate movement, but also by doing this redistribution of dose, also to help the Kiel approach of urethra sparing to be valid, and to lower even more the toxicity so GU toxicity. And the thoughts Roberto had, we had also, so which I explained in my first lecture. So we had to focus on very high risk. So this is where actually the patients, and nobody wants to treat, let's say, and plus C3A, C3B, so invasion of seminal vesicles, extra prostatic perirectal tumor growth, so almost T4, but also the classical high risk, high grade, high Griso score, high PSA, bilateral tumor, and 2 or 3 intermediate risk criteria for intermediate risk. Well, so in general, when using high dose in prostate, which method ever, there are these 3 zones you might should be aware and try to be careful and lower dose there, and also lower toxicity. So first of all, the rectum. Here we use the rectal spacers. I come back with more explanation. And then the urethra, actually what we have learned from the brachytherapy experience over decades, that not the pars prostatica urethra and the mid or mid-gland urethra is actually the problem, but especially the upper part of the urethra, so I would say the base urethra and the apex urethra are the zones to be, so to spare, urethra to spare. Now to the rectal spacer, this is actually a procedure which is in experience brachytherapy had no problem. However, we have introduced that in cooperation with the fellow urologist in order to create an agreement also on the indications for this therapy. So it works like this: a needle is placed parallel to the dorsal wall of the prostate, then penetrating the adenovia fascia and going to the perirectal fat, and then by live ultrasound, transrectal ultrasound, the 2 compounds of the hydrogel spacer were injected in the same time, and then this pillow of hydrogel is formed in about 10 to 15 seconds. It stays quite stable in form and size and location for about 3 months, which is more than enough for our treatment. Here you can see here 2 opposite situations. So on the left side, a tumor, a dominant intraprostatic lesion, which is dorsally placed, close to urethra. The ventral rectal wall is very close by to the margin of CTV, PTV involves, of course, the ventricular wall. So a difficult situation to deal with. On the right-hand side, a nice situation with a well-placed hydrogel spacer. And of course, if you are doing brachytherapy, for example, CTV margin will be the ideal situation. So CTV is equal BTV. Difficult to handle. So this how should you deal with in the particle therapy world with this opposite situation? So first of all, the first patient I showed you, this was a patient I have treated in the first lockdown in April 2020. So in the first lockdown in Austria. And you can see here that what you have to do, and there is no other option, is that you undercover the PTV in the region of intersection between ventrorectal wall and PTV, and to try, of course, to cover the CTV here. And if the deal is quite close by, of course, to take spatial attention of having enough dose in the deal region. That's why it's important, I think, even if you treat the whole prostate, to design and to delineate very carefully the dominant intraprostatic lesion. And I show you how we do it. In this case, you see here we handled it like this. This patient was treated not with carbon ions, but with proton therapy, hypofractionated with 3.1 dose per fraction. So the V70 of rectum is actually becomes with alpha beta 3 58, and this was 3%, which is acceptable, of course. The near max dose in the rectum was 59, so 2%, and the coverage was acceptable to take into account of this total dose in the hypofractionation. However, the second case, very similar, treated with protons as well, hypofractionated, you see here, with the use of the hydrogel, is a wonderful situation. So the V70, so in AQD2, V58 is 0%. The near max dose in the rectum is 29 gray, and the coverage is almost 100%. So that's really fantastic. So the gradient of the penumbra is actually in the spacer. So now, how we do define the deal for carbon ion radiotherapy, but I think this is general knowledge. So of course we use the multiparametric MRI, which is composed of course you know that, of T2 weighted MRI, DCE, color-coded maps, and the DYA, the ADC, MRI, and these three fused together will allow us to define in 3D where the deal is. However, this one of the studies like this one showed actually that when doing transperineal biopsies and correlating this exactly with the tumor in multiparametric MRI, and then after the prostatectomy with the specimen, that actually, yes, we can, and that's possible to localize by multiparametric MRI the exact location in 3D of the deal, but it is underrepresented in terms of volume. So we should actually add anatomical margin according to the internal anatomy of the prostate to this deal in a multiparametric MRI. This is you should do, and so that means this margin wouldn't go beyond the capsule, wouldn't go into urethra, but it follows in 3D the deal. So this would be then the GTV. Actually, at MedAustron, we also used in almost actually all patients PSMA PET and fused with the HITRI we used actually in our institute for planning. So and the sum of those, intersectional sum of those actually was the GTV. However, for those for the interventional radio-oncologists between you, there is actually also a lot of future in the so-called multiparametric transrectal ultrasound. And I would like to mention here two actually interesting procedures. The first one is the real-time elastography, which actually shows or detects harder, stiffer regions in the prostate gland, which are characteristic for PCI, and the dynamic contrast enhanced ultrasound, which is using gas-filled microbubbles as ultrasound contrast agent, and increase by doing this the macrovascular density of the affected region, and then you get this kind of color-coded maps in order to detect in real time ultrasound the deal. Why is that interesting, or can offer something on top of the MRI, of the multiparametric MRI? Because in the hands of an interventionalist, it offers you the possibility to place there quite accurately markers, and so determine this region for the real-time guidance on the robotic couch of the carbon ion in a carbon ion room or proton room much better. So I think that's important. Here is a special case of a T3A, almost T4 tumor. So in the MRI showing capsule rupture and extraprostatic growth, and in the PSMA PET actually tumor growth very close to the rectal wall. That's why in this case we have placed asymmetrical a spacer, which is not so easy to do, and it's advanced technique. And I think in general one should be careful in T3A tumors to place a spacer, but we evaluate these cases always in transrectal ultrasound first. Before we do this decision, then we actually act by doing by injecting the water inside asymmetrically. And if we see in the ultrasound that this is possible to place safely the spacer to avoid contralateral too much dose in the rectum, that's fine. If it's not possible, if you interfere with the tumor region, that should be, then it's a contraindication actually for the spacer. Then the urethra. So when applying high doses here, the apex urethra, that might cause strictures. We know that from the HDR experience, and then the consequence would be obstruction and the need of surgery, of dilatating surgery of these structures. As I said, increased radio resistance in the mid-gland urethra and in the base urethra, so the bladder neck, the trigonum region especially, that would be linked with, so high doses there would be linked with increased incidence of long-term cystitis. When you look to the urethra anatomy, that's indeed the case that the prostatic, so the mid-gland urethra, has a different anatomy, and that explains possibly the the different radiosensitivity. And there, I don't want to mention that yet. There are some publications from the brachytherapy world showing that difference in radiosensitivity in the 3 level of urethra. This would be now a typical strong protocol for high risk case, so not a very high risk case, a high risk case, meaning we treat here electively the lymph nodes, but the lymph nodes are not involved clinically. So we have as explained, the GTV definition of intraprostatic and possibly extraprostatic disease by using multiparametric MRI and PSMA PET, both of them. We are using MRI after the implantation of the spacer and of the markers of the gold markers, and we try to do this simulation MRI and CT MRI. We do that at the same, not only at the same day, but with the same filling of bladder, the same volume, empty rectum, and we have strict rules how to get the patients to have full bladder and empty rectum, and we check on this. This is important first to do the MRI for planning after the implantation of the spacer. So you have the anatomy of the spacer or the anatomy of the pelvis, including the spacer. Otherwise, there is a discrepancy between planning CT and planning MRI. Then the CTV1 includes the entire prostate, including GTV, of course, but minus urethra. The base of seminal vesicles, however, when seminal vesicle is involved, so in T3B, we would include that entire seminal vesicle in CTV1. And as I said, we treat also the pelvic lymphatics and include those in the CTV1. We treat the common external iliac intern node stations, cranial presacral nodes, and obturator nodes. So we don't go to the deep paraortal nodes. So in this sense, I think we are the first, to my knowledge, at least the first institution worldwide to use any for high-risk prostate cancer, so elective node irradiation with carbon ions. And then the CTV2, we applied normally at a sequential boost, would include the entire prostate, including GTV, minus urethra again, the base of seminal vesicles, and also, again, the entire involved seminal vesicle in T3B. So is dose intensification according to Kiel rules, so QD2 over 95. The schedule in carbon ion fractionation is for CTV1, 9 fractions of 4.8 gray, to the dose of 43.2 gray RBE. And then, as I said, sequentially, another 3 fractions to the CTV2 of same dose, 4.8 RBE to 14.4 gray RBE, total boost dose, and the total dose would be 57.6 gray RBE. The dose is applied in 3 weeks, meaning 4 fractions per week. This is Japanese experience, and we follow that carefully. And as Piero Fossati explained, so these 4.8 gray RBE are actually translated from the RBE model, Japanese RBE model of 4.3 gray. Yeah. So we actually use this multimodal approach of target coverage of both RBE models, PTV2 and CTV, as you can see here, and for the LEM1 and for the MPM, and try to make sure that both are fulfilled. And that's nice. And it gave me also, let's say, some freedom and also reassurance that that we are able to follow reproduce the Japanese experience with our differences, which I explained, but to be sure that the dose and dose fractionation actually is confirms and is the same, basically used over decades in Japan. Now, the reducing toxicity strategy in the urethra and the spacer, you see here the spacer in the sagittal view. There is not always, like in this case, I don't want it to show you only, Congress slides. So sometimes the spacer, it's a bit asymmetric. So in this case, this one is a bit too cranial. I would actually prefer to have the spacer here down, all along down here to the apex of the urethra. But not every spacer is ideal. However, it's still always is an advantage to have a spacer, even if it's not ideal. Then we have these three sections of prostate, urethra to follow, and we lower the dose here in the base, in the apex, according to D2. Of 1 gray, and avoid, of course, hotspots in the mid-gland urethra. There we don't try to lower the dose, only in the urethra to spare parts. It's also possible to have a nice pairing, as you can see here, of small bowel with carbon. And we also place, similarly to the patient showed by Piero Fossati with the sacrocordoma, we place the patients prone, and we treat the CTV1 with 3 different beams. So actually 4 different beams, 2 from dorsal with the vertical beam, and 2 from the lateral side, but inclined. So we use inclined for the large volume for the CTV1. We use inclined beams from down, so coming from down, in order to save, if you can imagine it in 3D anatomy, better the small bowel and also the colon. Then when we go to the CTV2 to treat the boost, we can still keep the patients in prone and then treat with 2 laterals inclined from the upper side. And you see here that also the sparing of rectum is very nice too. These are so far the data I have actually just presented in Madrid at the PTCOG. So 27 patients treated so far with very high risk, meaning with oligometastatic disease, high risk, unfavorable intermediate risk. Median age was 72, median follow-up up to 28 months. So 1 and 2 years, we could say. EPSS was in median 7, ranging from 2 to 18. And we offered, of course, according to the guidelines, all patients hormonal therapy, so ADT, but only 14 from 27 accepted this hormonal therapy. That's in Europe somehow different than in Japan, where all high-risk patients were treated with ADT for 2 years. What was different than in the Japanese data, although we have actually treated the pelvic lymphatics with high intermediate doses, we had zero toxicity, not only grade 3, but also grade 2 zero toxicity, which is very nice, GI and GU. And also the acute toxicity was very, very low. Not only so no grade 3, but also very limited grade 2. So this was, I would think, maybe another level. It was also a spacer effect. Then the 2 patients who failed actually failed in biochemical control, but both of them then failed distantly. One of these patients was salvaged by surgery. Other one was salvaged by stereotactic treatment with a bone meds we actually applied ourselves. We had so far no local relapse. So local control was 100%. And of course, survival was 100% too. So now I show you some cases to have an idea how is the dose distribution. So this would be now a very high risk case. This was 50 years old male from Norway with N+ disease. This gentleman has presacral positive nodes in PSMA PET, but also on the right-hand side of the iliacal, parailiacal nodes, intern and extern nodes. And in these cases, our very high risk SIRT protocol is the following. So we actually include, of course, in the CTV1, as you see here, the pelvic lymphatics up to not only to the sacral 1 level, but then we see the last cranial lymph nodes, and we add 2 centimeters above this level. That's why in these cases the upper part of the CTV1 differs a little bit according to the actual involvement of the PSMA avid lymph nodes. And in this case, you see here, we went up to lumbar vertebra 5, upper part of this. So it's individual. And then we treat these patients with 9 fractions of 4.8 gray in the CTV1, and the boost of 3 fractions of 4.8 gray, which in the high risk we apply only for the prostate or involved seminal vesicles. We apply these 3 fractions also in the involved PSMA avid lymph nodes. So this very high dose is applied as well here regionally. This gentleman was treated in November and December 2021. So about 1.5 years now follow-up. The PSA dropped from more than 200 now to surgical level and stays there, unfortunately, to surgical level. What I presented to you from the Kiel group, so this 0.5 nadir PSA 18 months, which actually correlated with the further long-term survival. And on top of this gentleman is also side effect free, so no side effects. Of course, he gets dual blockade of hormonal therapy, and he accepted that. So ADT plus abiraterone. And so far, he's stable, is followed now in Norway by our fellow radiation oncologist there. And I make with him from time to time follow-up visits in presence, and in between, in the interval, I do Zoom follow-up. So follow-up by Zoom. So this is a nice case representing actually the population we actually want to focus. And I think in this population, I hope Professor Orekia would agree with me. I think carbon ion can make the difference. And in these cases, I really would like to do a randomized trial. I think that's important, and we should do it, despite the problems we have for randomized trials described already. Another case is this gentleman with a PSMA avid local relapse in a pre-treated prostate with 74 gray IMRT. Here we decided by using the procedure I actually explained to you before to use not only gold marker, but also to try to place again a spacer. And this was assessed by investigation in transrectal ultrasound with a very experienced urologist, cooperation partner from Baden by Wien. You see here the spacer placement was uncomplicated, was very successful, and this is, of course, very, very important in ray radiation. This gentleman was treated then with this protocol. So this would be our protocol for PSMA avid local relapse, 16 fractions of 4.15 gray RBE to the entire prostate, and a SIB, a simultaneous integrated boost to the GTV, which I explained to you how it is defined exactly, to 4.3 gray per fraction. And here again with the relative sparing of the urethra, which is here in this case is of course even more important than in the primary cases. He was treated up to September 2020, so we have now 3 years of follow-up in this gentleman, and the PSA dropped to a surgical nadir as well. He is also side effect free chronically. Now another representative case would be this gentleman with a salvage SIRT for PSMA avid local relapse, but not in the prostate, but in the surgical bed after radical surgery. This was again a PSMA avid local relapse. No other PSMA avid, this is of course the prerequisite, no other PSMA avid regions in these patients, so no distant mets. And we treat here again, like in the other case, the 16 fraction schedule by using a SIP to the PSMA avid local relapse of 4.3 and 4.15 in the region of the prostate bed, as you can see here, but also including the former seminal vesicle bed. This gentleman was treated, so with 66 years old, sorry, the other one was 77 years old. This gentleman is 66-year-old, was 66-year-old at the treatment. This was performed up to June 2021, so 2 years of follow-up. Also followed also the PSA dropping to almost 0.02, so to a really surgical nadir, and this is needed because there is no prostate existent, so we should aim, of course, in these cases to a 0 PSA. And the fourth case I would like to show you would be a salvage SIRT for PSMA avid local regional relapse. So this was 80 years old engineer, a patient who was operated, radically operated, and 3 years after was relapsed, not locally, but regionally. This regional relapse was operated again, and then he relapsed again with a PSMA avid local regional relapse you see here. And then we treated this gentleman with a 16 fraction protocol, the same one mentioned, dosimetrically or fraction wise, but the CTV1 included the former bed, because this patient was radiation naive, the former seminal vesicle bed, and we treated electively the lymph nodes up to the level of involved lymph node plus 2 centimeters, and then we placed the C-boost in this coronal view. So treatment was performed in April 2021. So also 2 years follow-up. No side effects, surgical nadir, PSA nadir was reached. So I think we can conclude that ultra-hypofractionation to a dose intensification by SIRT to AQD2 over 95 or equal to 95 was feasible, also including elective node irradiation to high doses. And I think, to my knowledge, we are the first in the world to do that. Then, due to superior SIRT physics, sharper penumbra, small spot size, and the interventional techniques mentioned, surely they played a main role, I think, allowed lower doses in normal organs, at least such rectum, small bowel, and urethra, and in the same time, higher doses in the peripheral zone of prostate. The results are so far promising and well in concordance with the J-Cross Japanese experience. Local control was excellent, and I think biochemical and distant control was, in these very negatively selected patients, quite good, with not 91%. We had no grade 3 toxicities, but we had also no grade 2 grade toxicity, which is especially important for me, because by doing first the any with high SIRT doses at the pelvic wall, that's of course, it's not obvious that the toxicity at long term is so low. Of course, we need longer follow-up. We need more patients. And there is a question, of course, if we should, what I mentioned actually already, we should do a randomized trial. No? When doing a randomized trial, we may discuss that later on. Of course, one point is we have decided now to treat loco-regional in these high-risk cases. And I think we can say it's feasible and it's doable. The Japanese colleagues, they have treated all the time, actually only locally. So very strict with ADT, 2 years in high risk, 6 months in intermediate risk. All patients got this ADT. However, only performed. So these, I think, are the main differences between our experience and the J-Cross experience. So I would like to, these are the protocols summarized. So I would like to end here. I think I am in time, and take your questions, if any, and possibly discuss interdisciplinary, let's say, the session.
Thank you very much, Professor. So we have 2 questions on the Google Sheet. Number 1, thanks for sharing your valuable experience in treating high-risk prostate cancer. How do you deal with daily variation of prostate position relative to the pelvic and lens CTV? Do you have a daily adaptation protocol, and how long does a single session take?
Yeah, so that's a complex question, but a very important one. Yes, of course, that's difficult when you treat the prostate only. That's, of course, then you can you can use the daily match on the gold markers, no, and adapt your beam to the daily variance of these gold markers. This is not the only point when you treat the pelvic lymph nodes. That's very important, no. That's why what we used is actually more the brachytherapy approach, or the approach of a brachytherapist. So when you don't like the anatomy, you have to control the anatomy. No? So that means that we really focused on a very stable volt there, checked actually daily, and then also the match. So we took 2 matches, one match on the pelvic bones to be sure that the lymph nodes are treated correctly, and the second match on the gold markers. And this difference, we actually analyzed this difference when it becomes relevant in order to have a mismatch or under doses of pelvic lymph nodes if you correct only for prostate. No? And so we could actually we actually found out that the difference between the 2 matches, if it's less than 3-4 millimeters, is no problem in the general dose distribution, and both, so the entire dose distribution is correct. So in these cases, there was no action. If the match, the difference between the 2 matches was higher, then a doctor had to be there and make the decision. And the decision was, of course, to take down the patients from the table and refill the bladder and empty the rectum if it is necessary. Yeah. However, by using the rectal spacers, as I said in the first talk, there is a stabilization of the prostate, at least in the ventral dorsal direction. And the second part of the question is how long does a single session take? Well, so there is, of course, beam on time, then there is table on time, and there is also, let's say, room in time. Yeah, if we go to the beam on time, so approximately, of course, it depends a little bit on the volume. To treat with carbon ions, the prostate only takes about 10 to 11 to 12 minutes. And if by doing these large volumes at the pelvic wall, then we have, of course, longer treatment times depending on the volume again, but up to 20 minutes. So around that, beam on time, table on time, then there is all the image guidance needs time, of course. So the matches and so on, and we do also the cone-beam CT. That means minimum 10 minutes per session, guidance session. And then the in-room time, so we end up in a large volume with room in time of minimum 40 minutes. That's true. So it's not fast. No, that means patients are in prone. They have a full bladder. They have a body mask. Yeah. So there is, of course, a challenge for many men. And in this situation, and especially for those treated, after surgery, where to keep a full bladder means the function of the bladder should be well suitable to that. No? The only alternative to this is actually to place a catheter and to manipulate the volume of the bladder manually prior any fraction. But of course, this is for 3 to 4 weeks, quite a challenge for the patients. So we didn't do that routinely. The second question is, what is the rectal spacer? The rectal spacer is hydrogel. It's actually hyaluronic acid. Yeah, it comes from surgery in general, where so these hydrogel spacers can be used, you know, to have a nicer cheek or whatever. So they are used actually for aesthetic surgery. So this was the primary purpose. But this product we're using is actually dedicated to prostate, and was, as you saw, analyzed in many prospective trials. I have also one of those in Germany. They also run with this product, no? Which I mentioned. That means this rectal spacer is actually only should be only used to treat prostate cancer, and this is has a FDA approval and a CE approval in Europe for this purpose only. Yeah. Theoretically, it can be used, of course, vice versa, to treat, for example, to treat the rectum and spare the prostate. Yeah, but the spacer is done for this. Yeah.
Okay. Are there any other questions? Okay, I'm not seeing any raised hands, nor am I seeing any in the chat, nor am I seeing any others in the Google Sheet. So, Professor Galalae, thank you so much for this very interesting lecture. It is really a pleasure to have had you with us, and an honor to have had you.
Thank you very much.